And yes, everyone. Thank you, Dr. Bandesha and the management for letting me present. So the topic I was given was basics of TAVR procedure, or the time that I have been given is 15 minutes, and I don't want to go past it anyway because we are already running late. So there will be a few things that we might have to rush through, but hopefully we'll be able to see some of the things that are the basic fundamental steps of TAVR. ये आगे किस तरह जानी है? So these are the few things that we always look at when we are doing a procedure, and I think the 70% of the actual procedure is understanding the CT and analyzing how a person's particular valve and its vascular anatomy is going to behave while you're doing the TAVR. So these are few of the steps that we have to go through. So first thing is vascular access. Vascular access essentially means do we have enough room in the vessels to introduce our device, which is going to reach the heart eventually and sort out the aortic stenosis issue. Depending on what size valve we are going to use and what particular device we use. In Pakistan, we are mainly using Medtronic's core valve. So for that, you need around 14 to 16 French volume in their vessels before we can proceed with TAVR. In terms of anticoagulation and stuff, most hospitals would load them with aspirin Plavix the night before, and then just the regular dose of aspirin Plavix on that day. And in terms of heparinizing them, most acceptable target for heparinizing them is 250 before you introduce the valve, and essentially before you take out the dilator from the big sheath. Your ACD should be at this point more than 250. So once you have your access, and most of the time in Pakistan now, in order to save cost and also the fact that these 18 and 20 French Medtronic sheets are not available that easily, we are doing inline sheets. So what you need to do is, before you are actually introducing your wires and devices to cross the valve, you need to have a sheath that will at least take the balloon that you are planning to use for pre-dilatation. So once you have done that, you'll cross the valve. Again, in terms of crossing the valve, most people would prefer doing it in LAO view, but some of the senior operators prefer doing it in RAO. Whichever view you do it on, you need to make sure that you only advance your guide into the LV in RAO view, so you make sure you are at the apex. Once you are at the apex, you would change it with a soft wire to a regular pigtail, and inside the pigtail you would put the stiff wire. In terms of stiff wires, there are three commonly used ones. Previously, when I started doing TAVRs in 2015, we did not have any of these. We actually, other than the end plat super stiff, and we had to make these coils ourselves. And now we have these pre-shaped ones, the Medtronic's Confida and Safari wires, which are already pre-shaped. And one of the things that you get with them is that despite whatever sort of manipulation you do in the LV with them, they maintain their shape, whereas if you have made the shape yourself, they tend to lose their shape, which means there is a slight risk of ventricular perforation from the stiff part of the wire. So once you have your stiff wire in, the main challenge at this point is management of this transition zone from the soft coily part to the stiff back or proximal part of the wire. And this is the portion where the entire weight of the valve will be put on during the procedure. While you are pacing the heart, even when you are not pacing, one of the operators is going to be pushing forward, the other one is pulling the wire back. So this is the part which needs the most maintenance, and the person who is holding the wire needs to be cognizant of the fact that this part of the wire is always in your view. Even when you are changing sheets, even when you are changing devices at the groin level, we always make sure that we are looking at the tip of the LV, and we always keep this part of the wire under vision, and we make sure this does not move too much while we are manipulating, because this one step, other than vascular complications, this is the other most common source of complications in a TAVR procedure. Either you have a perf in your vessels or you have a perf in the ventricle. Most of the other complications are pretty easily manageable. Then comes the issue of fluoro load. So you don't really have to do it with the balloon expandable valve, but with Medtronic, you need to make sure it's loaded properly onto the delivery catheter system. So there are a few indicators that we look at in terms of our. So we put the valve under high magnification in an AP view. And then what we are looking for is particularly three things. One is obviously you look at the mesh of the valve and you make sure they're not impinging on each other. Second is these, if I can show you these tiny handles. These handles should be equidistant from this black part. So the distance, this white gap between the two should be the same. And the lowermost part of these two handles should be at the same height. And then the third thing we are looking for is the part where the device transitions into the valve, this particular light gray portion, this should be equal on both sides. So I'll show you a misload so you'll be able to see. Okay, this height is not is malaligned. This portion is sort of tilting on the other side, and you have all these mesh impingements on the valve, which means this valve has not been loaded properly. You need to take it out and put a new valve in. So most of the time we prefer doing a pre-deployment valvoplasty because that saves us from post-TAVR deployment ballooning, which has its own complications. So we prefer, if a valve is calcified enough that it might cause an issue with opening of the self-expanding valve, we would prefer that we do pre-ballooning or pre-BAV is what it's called. And what we do is that we measure the size of the annulus, and there is a minor axis and then there is a major axis. Obviously, in the echo era, especially when the TAVRs were started, and if you all know, I'm sure most of you would know that there was only one valve with which Cribbe started, and it was a 23 valve that was implanted in everyone. And it was based on the echo dimensions. And in echo, what we have found subsequently is that it always showed the annulus as circular, whereas CT data would show you it's elliptical. So there's always a minor axis and a major axis. And echo always gives you a smaller reading. So it looked beautiful on echo, but obviously as science progressed, we know that 23 is probably the smallest valve that Sapien makes now. So it wasn't the best, but obviously it was being done in high risk cases. So when we are doing a pre-BAV, we always make sure the size of the balloon is less than or equal to the minor axis. If you're using a non-compliant or hard balloons, we don't really have them, the true balloon or the barred balloons, at least from what I know in Pakistan, then you would subtract one to avoid perforation. So once you're there, you would make sure you have a temporary wire which is working. You would pace at around 140 to 150. Ideally, your systolic pressure should drop below 60 to make sure your balloon does not move when you're dilating it, because if your balloon is not stable, obviously there is a chance it might jump into the ventricle where it can cause a perf. If it jumps back up, it won't be effective. And if it's moving at its same axis, it can cause significant damage to actual valve leaflets, which means you will have a significant aortic regurg as soon as you deflate the valve, your balloon, and you might have a very unstable patient in the middle of your procedure. So when you are selecting a patient, and as I said, 70% of the cases actually understanding how the CT looks, you need to understand that aorta, again an amazing talk given before me by the master Dr. Anjum Jalal Saab, talking about the aorta, but from what we know in terms of our aortic orientation, it's like a 3D structure, as he said, and it has 3 curves in it. So obviously when you're looking at an angio, you only look at it in 2D and you don't really appreciate it, but the CT will tell you that it's very angulated in one direction. And once it's angulated, usually it's coming towards you in an AP view. And what it means is it can give you a false sense that your valve is properly oriented. That's why we use other maneuvers to make sure our valve is properly oriented at the time of deployment. So then the next step is introducing your delivery catheter, which should always be done under fluoro, and you make sure that your wire, the tip of your wire, is always under view when you are introducing it. Position the system in the native valve. We have already always done an aortogram before this, and we make sure that we are deploying these days in the cusp overlap view. Previously it was always the cusp or the coplanar view. Whichever one you do, you need to make sure you come into that view and you deploy it. But there are some caveats to it. As I said, there is a 3D structure to the aorta, and it's always calcified, especially when you're talking about old patients. So you need to make sure you're always looking. So when you are crossing your aortic arch, you always try to come in the LAO view, which opens your aortic arch up. And in there, one of the things that you see is how this nose cone is behaving. If there is a gap appearing between the nose cone and the valve, you need to stop pushing. Sometimes, and in fact most of the time, you can avoid this by just pulling on the wire a bit, so it just pulls away from the greater curvature, but sometimes it doesn't work. So most of the time there you need to either bring it back into the descending, rotate it by 90 degrees, then try to go back in. Sometimes that changes the orientation of the valve as well as the spines of the valve, so that helps makes it more conformable to the shape of the aorta. But the point here is you do not force. You don't force. It's already a sick patient. You cannot afford even a single complication in them. So you don't force it. And then if you're forcing it too much, there is a safety valve system in the device itself. If you force it too much, it just breaks at the back. And that means you cannot deploy it. You just have to bring it back up. But that requires a lot of force. A lot of times complications can happen long before that. But people, they have put in a safety check, but sometimes you don't reach that. Again, crossing the arch, make sure you have a loose grip, that you are not do it in LAO view, always under fluoroscopic guidance. You're always looking at the valve as well, again, as the tip of the wire, because that's where the complications are going to happen. And then you immediately stop advancing if there is excessive resistance. And then you can pull on the wire and stuff that we have already spoken about. I have 3 minutes left. We need to deploy this. Okay, so once you're in there, you align your valve capsule. So this is for the coplanar view. If you're doing it in the cusp overlap view, we usually start a bit higher, usually at the middle of the pigtail, and that's because usually it drops in when you start deploying it. So most of the times, most operators would be comfortable to start pacing from the start to make the valve more stable, because you're trying to avoid PVCs because they can push your valve up. But the main deployment part can easily be divided into 3 steps. The first step is from start of deployment to your annular contact. So this step is where you start. You haven't started deploying it. You would do an aortogram. You need to make sure you're okay. And then this first step is done very slowly, because you have not reached, this valve has not reached the other part of the annulus. So there is blood flow going to rest of the body. So you have not occluded the outflow tract. So you can take your time, because this is where your main deployment position is going to be. So you can take your time doing this. You can take all the images that you want, unless you have not done pre-dilatation, because in that case you might be obstructed. So this part is done very slowly. This is the first phase. So you start deploying it. So when you're deploying it, so there are 3 things that you're looking at. Again, as we discussed, the aorta is a 3D structure. So depending on which direction these 3 curvatures are, one is here, the other one is at the top, and then this third one is here. From this arch towards the ascending aorta, there is a third curve. So depending on how your anatomy is lying, your valve is going to behave differently in every patient. You might think, most of the operators just look at this angle and they say, oh, we'll have a high deployment stuff. But most of the time, it's these 3 curvatures which determine how well your valve is going to get deployed. So depending on how your valve is lying, so we call them the 0, 3, 6 positions. So if your valve is coming in a way that it's hugging the outer curvature or the greater curvature, then you need to start deploying deep. So you start pretty deep. You don't start at the mid pigtail level. If your valve is coming right in the middle, then you start like in your usual position, like 2 to 3 millimeters below. Whereas if it's coming and hugging the inner curve, then you start 0, because eventually it's going to go very deep once it's fully deployed. So you're always looking at how the valve is behaving at the back. And then, so this, I'll show you the next slide, actually, you'll see it better. So these 3 positions are primarily determined by the anatomy of the arch, but also can be controlled by the person who is at the level of the wire. If the valve is hugging the inner curvature, you can push on the wire slightly, and this valve is going to tilt more towards the outer curvature and make it more collinear with the valve. So you can get a better deployment depth if the person in the back is managing your wire well. If it's in the middle, you start in the middle. If it's hugging the outer curvature, you start deep. So you start, so this, once your first phase is over, this is your middle of the first phase where your valve has started deploying. You have still not occluded it, so you can take your time here. This is your capsule flare edge. These are the first 3 nodes, which we call as a 3 millimeter thing. So once you start pacing at this point, and what you are seeing here is that the valve now has hugged both the sides of the annulus. So now at this point, until so core valve, the leaflets are at this level, not here. So even if this part is fully open, this part of the valve has not started functioning yet. So that means your aorta is totally occluded right now. So this second phase is done very quickly. You come to a point of no return is what it's called, and you hear a cur sound in the middle of the deployment. The end of that point of no return is actually not determined by the tactile indicator, but it's determined by the gap between this dark part and this lower part of the deployment or delivery system. As long as there is a anyway, yeah, this arrow can get there. So at this, I'm trying to focus on this point because there are some TAVR implanters here, so this needs to be clarified. So as long as there is a gap between this dark band and the point where it says point of recapture, as long as you see some sunlight between these 2 points, this valve is recapturable. Once you go past it, you cannot recapture it. So at this point, you need to make sure your valve is fully deployed. And once you open the valve up to this height, the leaflets start working. So at this point, you can take your time, leaflets are working, and you make sure the position is perfect once you, because there's no rush. And then the last part, where you have seen the picture, you know that your height is okay, you take the parallax out. If things are good, at this point you can either take the pigtail out or leave it in. It's up to you, and then you deploy. The next phase after that is taking this nose cone out, which is the front leading part of the valve, and sometimes if you're not careful, this can get stuck in the valve and can take the whole system out as well. And then once you have taken it out, the person at the back who is deploying it is supposed to bring the entire thing back and resheath it so that the delivery system can come out of the body without much hassle. Vascular closure, you've done the aortogram, you make sure there is no paravalvular leak. I'm already past time, so I'll just go quickly through this. So vascular closure wise, what you do is most of the time we are using percloses. Some sites use 1 perclose and 1 Angioseal. So it depends on what you are comfortable with, but I think perclose is still considered the most safest way of closing these access sites. Thank you.